welcome to this morning's Seifeld, where our discussion will be on the opera. So I want to invite any students now to unmute and let me know where you would like to start. Just checking my audio. Can everybody hear me okay? We're good? All right. What character do you want to start with today?
We can jump right to it and I guess start with the clown, Joe.
So Joe. Now, Joe's interesting because he is one of the characters in the situational comedy that Larry David does provide some past psychiatric history for, although we don't know what afflicts Joe. We know that he is afflicted with a mental disorder. So what did you see in terms of this character's behavior? Wouldn't worry about diagnosis just yet. Just describe his behavior to us.
He was like all over the place. He was initially like crying, putting his hand over a candle, trying to hurt himself. And then he's making like threats towards one of the characters. Yeah, so he seems like all over the place.
Yeah, so the observation of all over the place, I think connotes disorganization. And with regard to his verbal communication, his threats, as well as the identified behavior of his putting his hand over the candle, certainly both disorganized thought process or speech, as well as disorganized behavior. Right? And right there, we can check two boxes with regard to positive symptoms of schizophrenia. So that's number one. If an individual presented with that HPI, with that history of present illness, and the clinician's initial impression was that this demonstrated disorganized behavior and speech, what other questions then would the clinician follow up with? What do you want to know?
Substance use.
Substance use, good. All right, what else?
Are you seeing anyone or anything anyone else isn't seeing, or are you hearing things that other people don't hear?
So perceptual disturbances, ruled out hallucinations, good. What else? Give me one more positive symptom. You give me hallucinations, we have disorganized behavior and disorganized speech. What's the final positive symptom?
Delusions.
Good. Right. So
and it seems kind of like the clown has with a little bit of paranoid or jealous, I'm sorry, subtype delusions when he's saying like, tell me who he is, you betrayed me with another.
Yeah, very quickly we see that Joe cannot distinguish himself from the clown in Pagliacci, right? And he kind of loses his identity with regard to the tragic character in that opera. And as such, he does have delusional themes of jealousy. And I think you were right when you mentioned paranoia as well, although it's a bit of a cheat because his paranoia is really fleshed out in another episode where he actually has thoughts about Jerry and a pervasive distrust with regard to Jerry Seinfeld, the character. So that will develop. Bottom line here is that he definitely has delusions. So, we've identified at least 3 of the 4 positive symptoms. It's probably noteworthy with regard to the neurobiology to identify that these are all symptoms that demonstrate something that is a pertinent positive that should not be evident at baseline, right? So it's the pathological presence of a sign that at baseline should not be present. Right? So at baseline, an individual, a functioning individual, should not have delusions, hallucinations, disorganized behavior, or disorganized speech / thought process. On the other hand, negative symptoms of the pathological absence of signs that should be present at baseline. Any thoughts as to whether or not Joe Davola demonstrates any negative symptomology?
I would say that his affect was kind of flattened at points of the show. He didn't display a tremendous amount of affective ability.
Yeah, I think the character does demonstrate a flat affect. I agree. So he possibly rules in there as well. So he has 4 of the 5 defining criteria of schizophrenia. At this point, what's the next thing that the clinician should consider? Somebody already mentioned that we have to rule out that everything that we're seeing isn't the direct and physiologic effect of a substance. So we already have one idea. There are others, though, that we have to consider here.
Medical
All-
conditions.
Good, very good. All the above cannot be due to an underlying medical condition. And then there are other rule outs as well. We have to appreciate that this condition is a diagnosis of exclusion. And in addition to a substance-induced psychotic disorder or a psychotic disorder due to another medical condition, there are 3 other considerations here.
Maybe, excuse me, a different psychiatric disorder, and this is just a psychotic break.
Yep. And what should be at the top of our list? There's 2 plus 1 that should come to mind here.
Like an MDD with psychotic features, or possibly like schizoaffective.
Excellent. That's 2 of the 3. That's exactly right. So, and the way the clinician really should address this is through a screening question, and maybe not a question that's necessarily posed to the patient, in this case himself, but a question to consider, and that is there a clinically significant mood component to the individual's presentation? Because if your answer is no, we can actually remove schizoaffective disorder as well as a primary mood disorder, that's major depression or bipolar, from our differential diagnosis. So we're not going to go down that path for Joe, but continue with our evaluation and continue with our differential diagnosis and add on an autism spectrum disorder. And that would be the final consideration here, as per the American Psychiatric Association, regarding which mental disorders the clinician must evaluate for and rule out in order to rule in schizophrenia, a diagnosis of exclusion. So, and that's Joe Davola. And we also know that at some point, somewhat introduced in this episode, but certainly fleshed out in other episodes, he is medicated, and that is, he is being provided a medication. We're never told what that medication is, and that when he discontinues the medications and he runs out, he actually gets ill again. And so he has established mental illness, and that mental disorder is likely in the psychotic disorder spectrum, that is schizophrenia and other psychotic disorders, with schizophrenia at this point being the most likely diagnosis.
Can I ask a question about this? So when I was watching, I kind of got the sense that this was like a egocentric sort of behavior for him, and he was saying like, I like leaving the door open to encourage intruders, and just it seems like he was not exhibiting distress with this. So I was getting the sense of maybe like a schizotypal disorder. And I know that you just said like he ends up being medicated in the future, so, and without the medication he relapses. But if we didn't have that sign, I guess, could you kind of help me in terms of why not schizotypal here?
That's a great question, and that's a great scenario to investigate. And again, to be clear, we're going to omit the medication history and a recent history of Joe Davola and consider his behavior in a pure context, hypothetical. Individuals with the personality disorders, and that would include paranoid as well as schizotypal and schizoid, do not have evidence of delusions or hallucinations. And even though I'm not sure Davola really has hallucinations, I do believe he has fixed beliefs that are not bound in reality. And if that's the case, I don't know if I'd be comfortable with regard to the single best answer that is the most likely diagnosis being either schizoid, schizotypal, or paranoid personality. The personality disorders are stable and pervasive, and without evidence of any breach in reality testing. And I think number one and number two, with regard to examples of such, would be hallucinations and delusions. And Joe Davola is quite delusional. I think that's the reason why. Now, having said that, I think you pick up on something that's very important. And while it may not come up on a shelf exam, it often comes up in clinical practice. We teach, I have taught you that the risk factors to develop this condition include 3 sets of traits that are so consistent and so reliable that we've provided diagnostic labels to them. And they are the paranoid, schizoid, and schizotypal personality disorders. They all confer risk. And unfortunately, that personality disorder, any one of the 3, being established, does not evolve into schizophrenia overnight. There might be several years where the individual continues to demonstrate their personality, like all of us do, with an onset of symptoms that only later in the course is identified, and quite frankly, sometimes retrospectively, as the prodrome of schizophrenia. So there's going to be a significant time course that the individual is going to demonstrate both sets of symptoms, not only schizophrenia or any other psychotic disorder for that matter, but its related personality disorder from the cluster A personalities that confer risk. And that's something you might be picking up on here, that his personality hasn't gone away. It's just that his fixed beliefs have been added to it.
Thank you.
We know he's a stalker. However, until he demonstrates that type of behavior outside the context of a psychotic episode, I would attribute his stalking behavior to the primary diagnosis. That's a difficult one to identify and to say there's a coexisting condition here. Nonetheless, it would make the treatment plan, but at least with regard to watching the opera, that aspect of the treatment plan is probably going to fall under the problem of schizophrenia on that problem list. Any other final thoughts on Joe? Any other characters in this episode you want to discuss? What's going on with Jerry and George in this episode? If you just relate or describe their subplot, I'm sure we can have that link to teaching points in psychiatry. Anything funny, interesting in any of the other characters' behaviors?
I guess both Jerry and George don't really want to go to the opera, and they really don't want to wear a tuxedo.
Any idea of where that's coming from with regard to George or Jerry for that matter?
I know on George's part, the tuxedo doesn't fit, and I guess they kept bringing up how it reminded them of a few years ago when he made a really bad toast at a wedding. That came up a couple times.
Good, keep on going with that. Let's focus on George here. Why doesn't George's tuxedo fit?
He gained weight.
He did. Most of us, when we gain weight, don't have a problem with our tuxedo, though. How come? Really? Why might a man not have a problem with his tuxedo, even though he's gained 20 pounds since their freshman year in college?
He'll buy a new one.
That's simple. What's going on with George here? Why does his tuxedo fit? What's the real reason? Especially the Dr. Gelfand's interns. We've been through this before with George, so I know you guys know. What's going on with this character that would prohibit him from buying a new tuxedo?
He's too stingy.
Yeah, yeah. We've discussed how George, I think somewhat ironically, demonstrates some core features of the obsessive compulsive personality, and that he's very frugal and demonstrates a miserly spending style. And I think I'm almost taking that verbatim out of the DSM in one of the diagnostic criterion for OCPD. Now, obsessive compulsive personality, I believe, requires 4 diagnostic criteria. And for the medical students who are going to be sitting for a shelf exam, you, especially for the personality disorders, you are not required to know the specific number threshold in order to meet clinical criteria and therefore most likely diagnosis. But I think it's noteworthy here only to say that even though George demonstrates this, as I believe is a core feature to his personality, having one trait that is potentially pathologic is not a diagnosis of a personality disorder per se, right? So that's something to keep in mind. And when we observe George over 9 seasons, I think we can all be rest assured that this is not an individual afflicted with obsessive compulsive personality, despite the fact that he demonstrates a clinically significant miserly spending style. And that spending style, that personality trait, results in that tuxedo not fitting and somewhat contributes to his not wanting to go to the opera, which itself becomes clinically significant, right? So that's George. What about that toast?
Jerry said that I think the biggest thing was that he cursed during it, and sort of, I guess, made it about himself, and the humor just did not land at all.
Yep. And we see this with George again as well. This character has significantly low self-esteem, and as such, does need to be the center of attention. So in that case, we go from cluster C and identifying his frugality as consistent with obsessive compulsive personality, and now switch over to cluster B, extraordinarily low self-esteem, significantly demonstrative of an external locus of control. Cluster B personality disorders, that center of attention that he gains from making that toast, and oh, by the way, multiple other scenes throughout the 9 seasons of this situational comedy, is consistent with the core feature of the histrionic personality, right? And this is why George Costanza is arguably the best fictional character in all of film, TV, and literature, pop culture. Anytime you focus on this character, the topic of psychiatry you discuss has everything to do with the episode you watch. He does not neatly fit into a single category. His behavior allows for the discussion of multiple categories throughout the entire DSM. And because his parents are parents that appear in most episodes, that is, they appear, the Costanzas, in more episodes than I believe Jerry's own parents, as well as Elaine's, etc. We get a larger glimpse of George's childhood than any other character. And as such, we can even talk about the child adolescent disorders as well. So his character is remarkable. And dare I say, an entire course in medical school can actually be created just by looking into the behavior of George Costanza. Right? So both cluster B traits as well as cluster C demonstrated in the opera. Any other thoughts on George? Just for completeness sake, we mentioned, or I mentioned, cluster B personality disorders and use the histrionic personality as an example. What are the other 3?
narcissistic, antisocial, and borderline,
Great.
I think.
Yep. And how about the other two cluster C personalities?
Dependent and avoidant.
Perfect. Yep. That's it. So you've got cluster B and cluster C down, and then we talked already, or at least alluded to, the cluster A personalities with regard to Joe Davola, and either or all may actually be part of his past psychiatric and developmental history. And those, again, include the schizoid, schizotypal, as well as the paranoid personality disorder. Any other characters you want to discuss? We have about 5 minutes left. Any other characters interesting in the opera? I think Kramer demonstrates an overt mental disorder, doesn't he? What happens to Kramer towards the end of this episode?
He runs into a clown.
So what's the problem with that?
It's just, it seems like he's scared of the clown, and he says he's scared of clowns, and he's been since he was a kid.
Yep. Diagnosis, or at least your provisional diagnosis, if Kramer actually self-referred and came to you for help with that as his chief complaint.
Specific phobia.
Yeah, specific phobia. Now, I'm not going to ask you what the specific name is for fear of clowns, because the DSM, that is the American Psychiatric Association, really doesn't acknowledge it anymore. And for test taking purposes especially, we need to know that there are different subcategories. What are the 4 different subcategories of specific phobias? Number 1 is situational. Number 2 is animal. 3, environmental. And 4, blood injection injury. The one that Kramer demonstrates here, fear of clowns, very common specific phobia, is in that final category of other. Unfortunately, again, we can't create subcategories that would account for every phobic object. And that includes the most common phobic object, or at least one of the most common, clowns. That would be in the grab bag category of other. But I believe Kramer does have a specific phobia. Kramer comes to you for help. You identify his fear of clowns as irrational and clinically impairing. And now he asks what you are going to do for him. What's the treatment plan going to consist of here?
Exposure desensitization.
Good. All right. Otherwise known as avoidance response prevention. In a graded fashion, you will slowly expose him to his fear, therefore habituating him to that fear. If on a test you are asked what the behavioral therapy is called when you actually provide that final step of exposure day 1, what is the single best answer? So he comes into your office with a fear of clowns, and the next follow-up, when he comes in the office, you actually have someone knock on the door, ask Kramer to go open it for you. He opens your office door, and there, standing in the hall, is a clown.
Would that be flooding?
That will be flooding. Instead, test question, different question stem, you have him lie in a chair, close his eyes, and through relaxation exercises, present the mental image of the clown day 1. So it's an imagined form of flooding called what? Single best answer here is implosion therapy. So if you're asked on a shelf, implosion therapy is imagined. and flooding is real. Any thoughts on Kramer beyond his specific phobia?
I just thought it was kind of funny, kind of bringing it back to Jerry and George when they show up at Jerry's apartment in tuxedos and like, oh, why don't you have a tuxedo? I thought you said everyone dresses up. And he's like, well, I don't. I just thought that was kind of funny.
And what's your take on this? Again, not to pathologize every aspect of behavior, but we've seen this in Kramer pretty repetitively, right? So again, knowing the background, knowing the HPI and the past psychiatric history, what might you consider here if this is deemed clinically significant?
I guess he has a lot of, I guess, quirks and quirky traits.
Quirky, I think the word that is used in the DSM is bizarre. Eccentric or eccentricity is also published in the DSM. And this is, again, all consistent with both schizotypal as well as schizoid personalities. The idea here is that, I think in the lay public, we hear this as Kramer only is marches to the beat of his own drum. And I think in psychiatry or psychiatric circles, the idea may be that he operates in a fantasy world, with the emphasis on the word fantasy, because that is an ego defense mechanism, right? So he creates this inner world that allows him to buffer himself from what he deems threatening in reality, right? That's that retreat, that autistic retreat known as fantasy. Normal if in the course of development, again, we mentioned that children do have an imaginary friend. Children do have tea parties when there's nobody else in the room. And that is considered or deemed to be normal behavior. But Kramer clearly is outside that age range. And yet the defense mechanism of fantasy continues to operate, and sometimes in a maladaptive and clinically significant way. All right. So again, his comment probably shouldn't be taken in a vacuum. When consistent or repetitive and clinically significant, which we know, perhaps not in this episode, but certainly in prior and subsequent episodes, that actually is demonstrated. All right, we're at the bottom of the hour. We're going to close it here, and we'll invite everybody back at 12:30 for today's film discussion, and see everybody back then. Thanks.
Thank you.
Thank you.